Today I'm going to talk about mast cell activation, aka MCAS. So I might throw around the term MCAS quite a bit here, and neurologic manifestations in COVID. So those three subjects, nervous system stuff, mast cell, and COVID, are pretty big on their own. So I'll see how much I can mesh together in 30 minutes or so. We'll have plenty of time for questions at the end, though. Here's a disclaimer. You can read it. I am some people's doctor, but not most of the people's doctors here. So this isn't medical advice, that usual kind of thing. This is our overview. I'm going to talk about mast cell activation, mast cell disorders in the nervous system. I'm going to break it down into peripheral nervous system, which might be your nerves outside of your central nervous system. The central nervous system is your brain and your spinal cord in that area. So I'll talk about how it can affect both of those regions. I'll discuss various environmental triggers that are associated with mast cell activation. Mold's a big hot button subject, so is Lyme and tick-borne illnesses. COVID is going to be a focal point here today, though. But you can have all these together. There's no limitations. I'm going to discuss sort of where mast cells live and why that's important. So a little bit about what they're really all about and why this is why this is an important subject. Autoimmune manifestations, they come in many forms in the nervous system. I'll talk about some of the common ones like PANS, PANDAS, ANDALS, which is just, fancy term, adult neuropsychiatric disorder associated with Lyme syndrome. It's always a good one. And I'll talk about this concept of mast cells producing mimicking antibodies. So antibodies that aren't really all that relevant, apparently. So that really makes everything confusing, doesn't it? So we'll talk about that and various other things. I'll talk about mast cell responses beyond just histamine too, and treatments and all kinds of good stuff. So let's get rolling. What are mast cells? Well, they're part of your innate immune system response. So that's kind of that first line of defense to the outside world. So you might have them around your skin. You get a bee sting, big mast cell response. They serve a normal function. They may be around your sinuses, around your gut, around your blood-brain barrier, around your eyes. I mean, just all these different places, around your vascular system too, honestly, around the blood barriers there too. They communicate with various parts of the immune system. They're communicated to by various parts of the immune system as well. So sometimes activation of mast cells isn't just because of the mast cells, so don't blame them for everything. Although we like to, so we can if we want, but there's other reasons why they get excited sometimes. And they produce a lot of signals beyond histamine. I already mentioned that. I'll give you a big list. It doesn't matter too much, just there's more than just histamine. And then they line these vital barriers, as I mentioned, and that's some areas where the pathology may start in some of these neurologic syndromes. So yeah, let's keep rolling. So what is mast cell activation itself? It's suggesting that there's an abnormal, normal activation of mast cells. So not that normal stuff where you get a bee sting or whatever. Of course, bee stings can abnormally escalate into anaphylaxis. So when you get a bee sting, you shouldn't die normally. So mast cell disorders can come in many shapes and sizes. But what mast cell activation is referring to is an abnormal response, an abnormal activation. And it leads to the disruption of the homeostasis of the individual, their normal state of balance in their health and physiology. There's a lot of genetics and there's a lot of epigenetics. So people can be genetically prone to mast cell disorders, but anybody could theoretically develop them if exposed to the wrong epigenetics, i.e. environmental influences, infections and toxins being very common. And then there's the classical allergy type presentations with mast cell, asthma, urticaria, eczema, angioedema, anaphylaxis, as I mentioned. And sometimes things may not be quite so obvious. And there's some ideas of long COVID syndrome in certain individuals being in part a mast cell activation or mast cell mediated response. And do all of those individuals have asthma or common allergies? Not necessarily. That makes it complicated. So you can have different diseases with similar causes. So the mast cell activation may be a partial cause from the genetics or epigenetics and all that stuff, but the presentation may be completely different. So it may be this disease disorder due to mast cell activation, and maybe this disease, this disorder, due to mast cell activation. And mast cell activation due to, you can go further, so I'm not trying to say it's sort of the central, but maybe not always the origin. And then here's other common causes you can see at the bottom, the usual fellows: tick-borne infections, mold, mycotoxins, various chemicals, stress and trauma response, and yeah, COVID, you know. So what about mastocytosis? Because everybody talks about this, but it's actually quite not that common, really, honestly. This is more like a tumorous growth of mast cells. They aggregate together. They get almost like cancerous level out of control. I've seen a few of these people. This is not most of our patients, to be clear. These people will oftentimes not be very functional without high-end drugs and therapy, and sometimes even chemotherapeutic agents that reduce their mast cells down. So I'm not going to talk about that as much today. I asked that general question: are some folks more susceptible to the development of MCAS than others? Well, yeah, of course, there are some genetics. We don't know all the genetics, but the individual mast cells, whenever they do activate, it's suggested that they create possibly a genetic shift of some sort. They start expressing more of something, more expression of cytokines and various inflammatory responses and this kind of thing. So you're going to see more people. Some people are more prone to that than others, and those may be the people that have atopic triad when they're younger, asthma and eczema and the usual food sensitivities and various things like this. It's possible mom had something similar, dad has seasonal allergies, whatever. And then you can see the hypermobile EDS type spectrum of folks are more prone to mast cell activation too, which is kind of a complicated thing. I did talk about that in a separate conversation, I believe, about the triad, the trifecta, which is mast cell activation, dysautonomia, and soft collagen or hypermobile disorders, and where those all interface with each other. So yeah, and I mentioned here before that other things signal the mast cells, so we do have to consider that in terms of these susceptible individuals too, that it's not just the mast cells, there may be peripheral genes and other predispositions and stuff like that too. And since these conditions appear to be on the rise, or maybe we're just more aware of them, whichever comes first, but chronic illness in general is on the rise, and this is one portion or contributing factor to many chronic illnesses that are now. The suggestion is the environment is probably playing a big role, and that can come in many shapes and forms. And COVID created a lot of exposure to, a lot of things, stress response and isolation and trauma being one of them, of course, but a physical force known as COVID that initiated a lot of immune dysregulation in a lot of people. And then even before that, a lot of our environmental toxins, we don't even know exactly all of them and how they're affecting us, but there are a lot of them in the world. So it's kind of maybe a toxic soup effect, toxic load, whatever you want to say. Too much of it going on, that may be the answer. And like I said, my hypermobile folks. So mast cells produce more than histamine. I've said that. Here's a big list, and it's not an exhaustive list, but there's a lot of stuff in here, as you can imagine. So, more than just histamine. Okay. So what about the nervous system and mast cells? Well, they are sometimes just proximal to the site of issue. So if it's central nervous system inflammation, or if it's peripheral neuropathy, whatever, they live proximal to those tissues. So if there's something that signals them or excites them, or something around those tissues for any reason, they're going to activate around those tissues too. And so that peripheral nerves seem to be susceptible, like small fiber neuropathies I'll talk about a little bit. They surround the blood-brain barrier, so it is possible for them to contribute to central nervous system inflammation responses of varying varieties, certainly brain fog type things, headaches, migraines, various other things of that nature. And airways goes without saying, gut, of course, other barriers. And those things can end up affecting the nervous system too. So the sinuses are proximal to your brain, the teeth and all that area, the oral cavity. If there's problems happening in here, it is possible for them to affect the proximal tissues as well, the central nervous system, or maybe it's through the blood, however it ends up working. Here's some conditions that are associated with mast cell neuropathies. I mentioned small fiber, common, autonomic neuropathy, POTS, dysautonomia, various other forms of autonomic dysregulation, gut dysmotility, gastroparesis, slow transit constipation type responses. It may affect and destabilize connective tissue worse than somebody's genetic hypermobility. It may make it less functional. It can lead to, especially if they have traumas on top of this, it can lead to instability. There's structure function illnesses that influence the nervous system. Craniocervical instability is one of them. It can affect, well, multiple things, but cranial nerves 9, 10, 11 are suggested here. The blood flow to the brain can be influenced by structural mechanics, and even the mast cells being around the vascular system itself may impair or impede flow to the brain. So that can happen in many different ways. One of the ways that recently has come to light is pelvic venous congestion syndrome and POTS dysautonomia. A certain percentage of folks have anatomical variances in their vascular structure, and then they develop mast cell activation or get infections or something else, and then suddenly they have POTS. And then if that gets corrected by, even in some cases, stenting or opening up that vascular flow, then their POTS may improve or go away. Quite fascinating. So there's a structure function dynamic that interfaces with the nervous system, interfaces with mast cells, and all of it in between. And then they may contribute to autoantibody formation. Some of those are real antibodies and some of them aren't, but you don't assume that it's one thing or the other. You have to kind of explore a little bit. But autoimmune manifestations can be driven in part by mast cells too. And yeah, we'll talk more about that in a little bit. So here's more about the mimicking antibody theory. So this was sort of a new thought that came out recently, and this was published by our colleagues, the great Dr. Lawrence Afrin and Tanya Dempsey, among others here. And they mentioned that we've known for a long time that our body produces these antibodies and some for normal immune system responses, but some of them are not that great, I guess, in terms of how easily they can, how specific they can be to the intended target, how well they can actually influence that particular target. And so you may think, well, that could happen with autoimmunity too. Let's just say an antibody is created to something that the body thinks is a pathogen, but it is so not going after just that pathogen. Now it's going after you too. So it can get confused sometimes in the process of creating antibodies. So these imperfect antibodies may also serve a purpose in some cases. You've heard of people who've never had COVID before. Maybe it's possible. It's either their innate immune system or maybe they have antibodies to other coronaviruses and they're not specific, but they're good enough to go attack that new virus coming into the scene. So the cautionary tale, according to Dr. Afrin and these folks, is that if mimicking antibodies do exist from mast cells, one may appear to have an autoimmune condition with autoantibodies. And you may go attack it as such. You may try to treat it as such. But maybe that treatment doesn't work because the root of those autoantibody responses is actually mast cell activation or mast cell disorder. And so one thing I've been very cautionary about is how I test for infections in the context of this, because I may see antibodies to Lyme or other things like that, but do I know that that is the primary problem with that person now? Is it possible I can try to look at it from other lenses when I'm really not certain? But that's what I need to be targeting at this moment, especially when they have a lot of clinical mast cell activation features. In that case, I might try to use more direct testing techniques, meaning I'm not going to try to rely on a disjointed antibody system. Maybe a lymphocyte system in some cases might be better, but maybe not. I might go to direct testing. So with tick-borne, we've been using a lot of these RNA fish type tests lately, which I can talk about later if anybody's interested. So some thoughts on mimicking antibodies, kind of a newer concept, but worth mentioning as we continue to unravel it, but we still don't know all the answers to these things. So how might COVID fit into this whole thing? Apparently, a certain subset of people who get COVID, and even it could be acute COVID, it could be post-COVID or long COVID, it can be vaccine-induced long COVID. all those situations can lead to some sort of chronic manifestation that in a subset of people is partially driven by mast cell disorder or mast cell activation syndrome. That's what it really comes down to at the end of the day, is that there are subsets of people that respond to mast cell treatment in long COVID. And how do those people present? I'll talk about that in a minute. They have a lot of the common features that you may see in mast cell activation, dysautonomia, chronic fatigue, ME, all that loveliness. So here's some possible mechanisms. I don't think we know entirely, but persistent viral RNA and spike protein seem to be a culprit in COVID. Our bodies don't always get rid of these things quickly, and this may happen with other infections. There's some theories that even the residual outer surface protein of Lyme Borrelia may be persisting in some people's blood or body somewhere, and they're not even alive anymore, but they're still causing persistent immune activation. So that's a theory. Maybe in a small subset of people. I don't think it's the answer to everybody. Some people may not form neutralizing antibodies effectively to spike protein too. That's another theory. So there may be a certain subset of people that are specifically susceptible to spikeopathy, spike protein mediated, illnesses, which means those people may not be the best candidates for mRNA COVID vaccination as well, because the mechanism is increasing spike protein artificially. And then you can see the vascular wall endothelium often becomes damaged in COVID cases. You'll see a lot of people having excesses of fibrin in various things. Well, those mast cells are also present at that particular site. So if stuff is acting weird there, whether they're the culprit or not, they're getting signaled. So if they get signaled, there's a chance they'll go into MCAS. They'll go into abnormal signaling process, and they change their status quo from normal reactivity to abnormal reactivity. There's some suggestions of persistent, monocyte activation. That's Dr. Bruce Patterson's theories. I've kind of mentioned them a little bit here. Direct damage to the blood-brain barrier, sort of mimicking traumatic brain injury. You may see mast cell type responses in traumatic brain injury for people too, any kind of trauma, any breaking of the blood-brain barrier, allowing a closed system to now be open system. Toxins will get in there. Things that normally aren't supposed to get in there will get in there. And the immune system, the microglia, inclusive, which is another part of your immune system in the brain, can become activated, but so can mast cells. And so neurologic long COVID may look a lot like traumatic brain injury, and a lot of the inflammatory markers may look the same, and the microglia activation may look similar too. And so if you have a brain injury and COVID, that's usually worse, actually. So folks with a history of traumatic brain injury that then get COVID are more susceptible. Doesn't mean they all will develop neurologic long COVID, but they can. They're more likely to. And the mast cells are part of it. It's not the whole story. The microglia, as I said, whole separate conversation. Secondary infection reactivation. COVID suppresses the immune system response, so you're going to see more viral reactivation, maybe reactivation of tick-borne infections. I've seen people harboring several tick-borne infections and taking care of them well until COVID hits the scene, and then they're not taking care of them very well. All those things can excite the mast cells, and they may interface at all the different areas which the mast cells live as well. The blood, the connective tissue, the gut, all these different areas, sinuses, whatever. Worsening environmental toxin illness. I've seen this too. People maybe handling mold a little bit better. Maybe it's in their environment, at their work, in their life, and then suddenly COVID comes, and now they've become hypersensitized to it. The inflammatory, what their body had done to that point to mitigate these things is now, not working as well. It's taxed, it's stressed, it's not operating as efficiently as it once has. Heavy metals, other environmental toxicants, all inclusive. So these are just some theories, right? And there's probably even more than this, and I'll discuss more later. And if anybody wants me to speculate further, I can speculate further too. Blood-brain barrier. Can you measure the leakiness of the blood-brain barrier? I just wanted to put a little thing on here because this is a test that you can run S100B through LabCorp even. And there are other specialty tests out there, like I have no financial relation to them, but like Cyrex, for example. Precision Point has like a gut test that's in the blood, but it also measures zonulin levels, for example. And generally, if the gut is leaky, the blood-brain barrier has a tendency to be leakier. They kind of do interface. There's a very complicated gut-brain circuit there. And sometime maybe I'll talk about that as a dedicated discussion because it's really, quite quite fascinating. We're learning more about it. So targeting treatments towards repairing the blood-brain barrier and the gut barrier at the same time may be helpful as I get to treatment here in a little bit. So here are the most common post-COVID or long COVID presentations in the nervous system, and any one of these presentations could interface with mast cell disorder in some people. Dysautonomia, as I mentioned, that's just general autonomic dysregulation. So these unconscious forces in our immune system that control our heart rate, blood pressure, and gut motility and sweating and all these different things stop working properly. Heart palpitations are extremely common. They're also common in POTS. POTS is common in long COVID. POTS is common with mast cell disorders, all that kind of stuff. Postural orthostatic tachycardia syndrome. Chronic fatigue type presentations. Oh gosh, there's so many chronic fatigue presentations. So if anybody ever tells you you have chronic fatigue, they don't know anything about what's actually going on with you. That's such a blanket term for a symptom, syndrome diagnosis, so to speak. But this can happen, brain fog can happen, all of it common. Headaches, sleep problems, smell, taste deficits, these are all neurologic symptoms is what I'm getting at here. I mentioned small fiber neuropathy, muscle weakness, progressive weakness, autoimmune illnesses, worsening or developing. Some of those can be in the brain, the nervous system, autoimmune encephalopathies, neuropsych presentations, worsening or developing, brain on fire type stuff, those kind of things. Gut dysmotility, gastroparesis, or constipation, or just more bloating, more SIBO or SIFO, small intestine bacterial overgrowth, or small intestine fungal overgrowth, often marked by low bifidobacterium, which also seem to help our immune systems and our brain work better. So kind of an interesting thing. And I mentioned PANS, PANDAS, ANDALs, all these different things. So is there a mast cell mediated PANS, PANDAS? I was kind of taught there may be. Well, there's a certain subset of folks, these are kids usually, pediatric autoimmune neuropsychiatric syndromes associated with strep or other organisms, basically, PANS being the other organisms variety. There's a certain subset of these folks that clearly do have some variety of mast cell disorder. If it's not one thing, it's another, but it seems when you treat their mast cells, you may have better outcomes, and it may be that if that's missed and that's not treated or recognized properly, it may be that other treatments don't work as well for them. And you'd like to think, well, maybe if I just find an infection and treat that, that's all I need to do. Or I'll put IVIG in my back pocket later, which could work for mast cell. I'll get to that. But it's important to understand when these kids have a lot of sensitivities, especially a lot of food sensitivities and other things, to common sign, you may want to look into this further. And those things may affect the blood-brain barrier integrity, the gut barrier integrity. You don't want, I talked about this in another talk, but you don't want antibodies, autoantibodies especially, that are formed peripherally in the gut, in the tonsils, in the whatever, to enter into the central nervous system. If you could avoid that, it may be a good idea to try to build up that blood-brain barrier. And one of the ways that you may want to do that too is to support the mast cells. It's possible. One way or another, just screening and treating when appropriate. So treatment strategies. I think I'm doing quite well with time. I'm happy about that. And we're going to talk about treatments here, then I'm going to take questions. So this is just general treatment principles. And I did narrow it down to like 2 pages, but I will gladly talk about more details as folks are interested and want to ask me. So of course, histamine is a major mediator. So I said histamine is not the only mediator of mast cell inflammation, but you can certainly give people antihistamines. There were studies on acute COVID, post-COVID, and significant improvements in symptoms and mitigation of some of the worst effects of the cytokine cascades, even in acute, with antihistamines. It's possible that they can work for some people. So use them if it makes sense, and they tolerate them, of course. Flavonoids are always helpful. They're our friends. They're mostly considered mast cell stabilizers. Some of them work more in the gut, like say cromolyn, quercetin. Some forms of quercetin absorb better than others. And then some of them work better in the brain, like say luteolin, for example, or resveratrol, perhaps. There's rutin in here too. There's a whole bunch of others. So even berberine and other things. You can use them. Figure out which one works the best for you. Just like antihistamines, there's sort of an analogy people use, like a lock and key. Everybody has a different lock or a different keyhole, perhaps. And the key that you're introducing, if it's antihistamine or a different flavonoid, may work better for one person and better for another person. So we haven't quite figured out how to not do a little bit of a trial and error type approach to mast cell yet. Maybe in a certain number of years we'll be more precise, but as it stands, unfortunately, there's a little bit of trial and error that happens with any of these treatments. Find the toxins and treat the toxins. Pretty important, especially if they're immune toxic toxins like mycotoxins, mold toxins, for example. They're quite toxic to the immune system. They hang out in the vascular space and they get into the brain and they're neurotoxins. I mean, it's important to figure them out. Heavy metals don't get a lot of love, but figure them out. Treatment of infections, sometimes quite important, especially certain types of infections are more likely to excite mast cells. The way the immune system responds to parasites and fungal elements is closer to a mast cell response. That may excite them more. But you may also see stuff like Lyme or other sort of, proverbial stealth infections, the tick-borne infections, even viruses. It's in their best interest. A lot of these are opportunists. It's in their best interest oftentimes to hide and prolong their own life and replicate whenever they feel like it. And if your immune system is vulnerable, they're going to do that. So sometimes you got to help out the immune system a little bit by killing them. It's possible. It's not all a killing story, but there's time and place. I mentioned gut dysbiosis and gut barrier function. I think the microbiome research is really getting exciting right now. We don't have all the answers, but we're certainly getting closer to understanding it, and there are folks out there researching specific effects of COVID on the gut microbiome, and that's where we learned about the low bifidobacterium, for example, Dr. Sabine Hazen, for example. Treatment of blood-brain barrier and vascular inflammation, mentioned endothelium, the neurovascular junction. I mean, like, your blood supplies your oxygen and your nutrients, and it also helps you get rid of waste. I mean, there's a lot of important things that happen at the blood barrier. So if those things aren't working right, when they first get inflamed, they often get leaky, and then they start getting then the body often starts producing a lot of fibrin, and it creates sort of an artificial barrier there, and it then affects the smooth diffusion of oxygen and nutrients into those tissues. And that can contribute to chronic fatigue, brain fog, pain responses, all kinds of different things. It's just suboptimal blood flow. Hormonal function, I don't think the hormones get enough love, although I know some people give them enough love, but yeah, give them enough love. Especially for the nervous system, there's a lot of neuroendocrine stuff you have to consider. The adrenals and the influence of cortisol, the influence of other adrenal hormones like aldosterone on, Pott's dysautonomia. I mean, there's all kinds of stuff here. Thyroid, every cell in your body requires thyroid hormone. The effector, or what the thyroid affects in your cell, is your mitochondria, which is your energy production system. You better bet that high energy systems like your brain and your muscles, like your heart and your other muscles, need a lot of mitochondrial function. So if the signal's not working, that's a problem. Sex hormones. Some of these sex hormones can make mast cell worse, and some of them can make mast cell better. Balancing them seems to make mast cell responses better. For example, too much estrogen may be more mast cell activating. Balancing it with progesterone properly. Progesterone itself is what's called a neurosteroid, along with pregnenolone and DHEA. Those can help with blood-brain barrier repair and lowering neural inflammation, all kinds of good stuff. And testosterone is often friendly for lowering neural inflammation too, in both men and women. So many other immune modulators out there. Yes, low-dose naltrexone, everybody uses it, I'm sure. Peptides, many peptides. I can talk more specifics, but there are a lot of mast cell peptides, KPV and Lexinox, TB4 for microglial stuff, among others. Been using lorazepam for gut barrier function, all kinds of stuff. And then I've been playing with rapamycin, low dose, very low dose pulse rapamycin for autophagy mTOR effect, which is apparently one of the pathways that also gets activated in the brain. Cellular senescence, when your immune system's asleep at the wheel, that may be one influence of COVID as well. And then there's the high-end therapeutics that we do sometimes when we need to, when appropriate, IVIG, plasmapheresis, or a combination thereof, plasmapheresis being full plasma exchange, blood filtration, getting rid of all those cytokines, all those autoantibodies, and all that funky stuff. It's not without its risks. There's time and a place, though. It can work for COVID and mast cell related responses in COVID sometimes. And I put this extra page in here a little later because I wanted to talk about some of the foundational elements too. I mentioned how some people are more susceptible to mast cell. One reason is also metabolics, nutrigenomics, whatever you want to call it, nutritional elements. There's people for the methylation here. DAO, breakdown of histamine in the gut, is a thing. Acetylation, that's B5 dependent pathway. Ways to sort of help the body metabolize histamine better. Diets as well. There's the obvious low histamine diet. There's elimination rechallenge diets, which are still the gold standard, getting rid of the things that are triggering. At least when people are really reactive, the goal is never to keep people on restrictive diets forever. But if, you know, the one thing we do have to put in our mouth every day is food typically. So if that food is, you want that food to be nourishing you and serving the current situation. And sometimes we do have to be a little more restrictive in the beginning, but I always tell people we're going to try to open that up later. And I do, there are desensitization strategies I didn't put on here too. One of them is I really like is low dose immunotherapy, for example, formerly low dose antigen therapy, goes by many names. It's a good one too. Stuff for the brain, keto, temporary keto. You don't have to live in keto forever, or exogenous ketones like oxaloacetate. Those are basically fat, protein, very low carbohydrate diets. They have traditionally been used for seizures and used in the cancer world quite extensively. They can help sometimes with these syndromes temporarily. And then there's all these different endotoxins. I mentioned oxalates, especially if there's mold and fungal elements or leaky gut type things. A lot of these internally generated toxins that are listed here can affect the brain adversely. Oxalates, ammonia, uric acid, porphyrins, which are metabolites of hemoglobin, reflecting liver functioning in a lot of ways, sulfates and different things of this nature. So yeah, all this stuff affects the brain, so it's important to look at. Stress management and biofeedback and neurofeedback. Yeah, I wanted to put a little plug in for that. I think it's quite important. Got to remember that cortisol releasing hormone is a trigger directly for the mast cells too. When the cortisol shoots up, the mast cells can get quite excitable. So in the limbic system retraining programs, there's many of them out there. DNRS, Gupta, Primal Trust, several others. So about at the 30-minute mark where I wanted to be for questions, I will go ahead and stop screen sharing here. You can get more information at our website, Gordon Medical here, and yeah, we'll review more at the end, or Darcy will here. So I'm going to go ahead and stop sharing so you guys can see me better. Here we are. So I'm going to open the Q&A, and I'm going to answer some questions. Is there a medication or supplement that inhibits the mast cell mediator elastase 2? Directly, I'm not sure that they've developed a specific drug there, but mast cell stabilizers broadly can help, or mast cell diets, or any other techniques where you're lowering sort of entire mast cell activity, I think can be quite valuable for that purpose. Because we do see when we give people antihistamines and stuff too, sometimes that's enough stability to improve connective tissue function and other things too. So it's kind of relative. Okay. Do you not agree with Dr. Klinghardt that MCAS is also caused by chronic exposure to EMF from cell towers, Wi-Fi, phones? I didn't mention electromagnetic forces, but I believe it's possible. There's a certain percentage of the population that is quite sensitive to it, and it does seem to interface a lot with multiple chemical sensitivities. So MCS being sort of a related condition to MCAS, and then EHS, electrohypersensitivities, they seem to be sort of an associated spectrum. So is it possible that they're affecting mast cells? Yeah, absolutely, it's possible. We just don't know yet for sure. Thoughts on infecto labs for vector-borne and viral testing? It is really good for viral testing, and I've used it extensively in vector-borne illnesses too. I think that there are times when, so just to be clear for everybody, Infecto Labs uses ELISpot technology, so it's lymphocyte response testing. I find it really helpful for post-COVID immune infection reactivation, especially in like Epstein-Barr virus, CMV, mycoplasma, chlamydia pneumoniae, those run-of-the-mill characters. And when it's helpful for tick-borne, it's very helpful for monitoring treatment. So if you measure positives either through Infecto or Armin Labs in Germany, and then you treat, oftentimes you'll see that correlated. the improvement correlated in the infected lab. So it is good when it's good, but you have to assume that the lymphocytes are functioning properly, and sometimes they're not. Okay. Are there any supplements that help get rid of spike protein? There's some suggestions that there are. There has been some research on fibrinolytic enzymes, nattokinase and lumbrokinase, specifically probably serrapeptase and maybe bromelain or something like that. Usually, if I think there's a lot of spike protein still in the system, like I'll look at and see there's really ridiculously high IgGs to spike protein, which is more common in vaccinated folks than folks who have not been vaccinated. Or I might see evidence of microclotting. So there's tests that you can look at that. That's, fibrin amyloid aggregates, possibly with spike protein related response. I don't know for sure, but I'll do rotations with all three of those: lumbrokinase, nattokinase, serrapeptase. So I do think it can work over time, because I've seen the microclot profiles and the fibrin profiles improve. So the assumption is the vascular inflammation is lessened, and cytokines will improve too, sometimes. Could the COVID vaccine also cause persistent spike protein or viral RNA fragments? Well, I don't know if there's viral RNA in most of the vaccines, but there's definitely spike protein creation. I'm pretty sure that all the vaccines out there have targeted spike protein in some way. And so, yes, you can have spike protein mediated illness from vaccine only. So I've had several patients with complex neurologic syndromes that were almost primarily injured by the vaccine, not so much the COVID virus itself. Okay, hopefully that answers that. Why specifically food allergies? If a person has 22 environmental allergies, including animals, dust, plants, etc., why would this not be enough to be considered? Oh, I wasn't saying it's only food allergies. You can be reactive to all kinds of other things too. What I was trying to get at is that not every mast cell activation person is primarily a classic allergy person or a classic multiple chemical sensitivity person anyway. So yeah, but if you're seeing a lot of that stuff, I mean, there's something going on. The mast cells are getting oversignaled regardless. Very curious about blood-brain barrier and tests to determine. Oh yeah. Who should you talk to? Some of the functional practitioners, perhaps, or folks like ourselves who work a lot with complex chronic illness. Some neurologists are catching wind to it, although it's strange that the blood-brain barrier is sort of still feels like a newer concept. It feels like it's still a frontier to explore amongst most conventional neurology. But there are functional neurologists out there that'll explore it more. But I mentioned the SB100, I mentioned Cyrex, I mentioned measuring zonulin levels. Yeah, there's a few tests out there. Regarding helping the immune system by killing viruses, are there any supplements that kill herpes type 1? Yeah, I mean, any herpes virus will respond to lysine, for example. That's just an example, but lysine blocks arginine uptake. They don't get as much food. That slows their replication. There are a lot of herbs that can help. Olive leaf, lemon balm, Chinese skullcap, andrographis sometimes. There's a lot of herbs, basically, is what I really like. And then there's those nutrients. Vitamin A, if it's dosed safely, I wouldn't just go crazy on vitamin A without supervision, but there's some ways to approach it for sure. What direct and indirect strategies can one employ to fall beneath the radar of mast cells starting to react? Wait a second, am I reading that correctly? Fall beneath the radar of mast cells. I'm not sure if I understand that question. I guess I should say that like lowering the threshold, perhaps, to mast cell activation, like mitigation strategies, maybe. I think that could probably come to good gut health and clean living there. Honestly, in terms of good prebiotics and good diversity in your microbiome. I think it starts there to some degree. If you have sensitivities and stuff, avoidance is still a good thing when you're trying not to trigger them. But you don't always know for sure. Other than that, I mean, there's like vitamin C, quercetin, and really easy things you could take preventatively. Okay. Can you talk about prevention of COVID beyond the vaccine? How effective are things like iodine spray, gargling with Listerine, and other kinds of nasal sprays? So nasal sprays do make a lot of sense, functionally speaking. Like that's where the virus enters. So if you immediately start jumping on certain nasal sprays, I think it can be quite helpful. So yeah, you have the iodine, I think it's 3% or less. You have the like xylitol, like X-Clear type spray, you know, with the grapefruit seed extract. You have silver. You have even just saline rinses, just like a saltwater gargle. Saline can lyse viruses, so even just saline rinses can be helpful. And then there's, you know, zinc and quercetin and these types of things. There's a lot of preventative strategies, getting your vitamin D in a proper range, vitamin C, all that kind of stuff. And then depending on what your individual susceptibilities are. Why do you say a low oxalate diet is especially helpful in mold or fungal situation? Oh yeah, because Candida and Aspergillus, I believe, can sometimes produce oxalates, and they can also disrupt gut barrier function. So it seems like you can look at the organic acid test, and it sort of looks at it from that angle. That's, you know, that's one way to sort of, you know, screen that angle. But yeah, it's worth considering or going after fungal elements, Candida even, which is very common in post-COVID syndromes. Reactivation of Candida is very common. Testosterone, even in women. I'm not thinking medical professionals are testing. How can you encourage them to? Well, I mean, you know, I think like certain OBs might if they do HRT, but you're right. I mean, conventionally speaking, it's maybe not that common, but a lot of women improve from a very small dosage of testosterone. It's often 1 to 5 milligrams, and it can improve neural inflammation, brain fog, energy, endurance, you know, chronic fatigue symptoms. It's often well tolerated in most. I think if you do too much, you might get a little more aggressive. And the, you know, the pellets, those are a little too zingy, but I've seen women in the 300 range with those. Apparently they feel good, but I don't know about pushing it that far. But you know, that's something people do. Um, May I ask how long the low histamine or mast cell diets should be given a try to see if they'll make a difference? And what are the pitfalls while doing an elimination diet? How does one do that accurately when it's said to be so physically and emotionally difficult? Yeah, I mean, working with somebody I think is really important. There are some nutritionists that are mast cell specialists out there. I wish there were more, honestly. And, you know, with all respect to nutritionists, I mean, some people don't understand how complicated this is, and they focus very heavily on the emotional component. So they say like it's mindset. You know, if you're going to think you're going to react, you're going to react. But not everybody. But I've gotten into this sort of, you know, tailspin there. It's like, well, short term, you know, you do need meal planning oftentimes to make this work easier. You need a wholehearted elimination, like a wholehearted elimination of certain things, at least 4 to 6 weeks in an ideal world, then a re-challenge phase. You need to work with your doctor or your nutritionist or somebody, your naturopath, somebody who's a little more nutritionally minded, I think. Are you seeing any relation to optic nerve disorders? Yeah, you know, it's a good question. I do. I have seen that. I've seen some research on that too. And I think that the vascular flow to the eye can certainly be impeded or affected, and I've seen problems with that. And I don't always know if they're completely COVID related, but they do get worse after COVID. I've seen even rapid development of cataracts and various things at a higher rate than I've seen in the past, and I've seen all kinds of other vascular changes in the eye. So you know, it's certainly possible. What are the peptides that are beneficial for MCAS? Oh, I'll just shoot them right out here. Let's see. KPV and Lexinox, TB4, the gut barrier support, I think, can be helpful, which is like the lorazepatide. And the BPC 157 can also help gut barrier and blood-brain barrier support, among other things, and kind of help with the liver. And then let's see if I'm missing any. Those are the big ones, but there are a lot of indirect ones too that if I think of them, I'll let you know. Palmitoylethanolamide or PEA inhibits MCAS. Yeah, PEA is cool. I like it. And it's like a cannabinoid that modulates inflammation but doesn't make you high like cannabis. So, you know, go for it. Are people with HEDS prone to more hyperinflammatory reactions? And how does this change treatment approaches for SIRS mold and Lyme? Oh yes, they are, and you got to be really careful because I did a whole talk on like Herxheimer reactions and mitigation. Not everything is a true HERX2, but you got to be careful with this population. People causing more inflammation and specifically more inflammation in their connective tissue, or in some cases their gut. You know, oral tolerance can be very challenging sometimes with this population too. So yeah, you got to be pretty careful. That takes somebody with a little more specialty and know-how sometimes. Does cromolyn sodium break down collagen? I don't think so. It doesn't even leave the gut most of the time. Cromolyn sodium can lower mast cell response in the gut, but that can also lead to lowering mast cell responses peripherally. I'm not aware of any detrimental effects on collagen, but anything's possible in this world. Wondering about a differential for autoimmune encephalitis versus PANDAS. Yeah, I know. That's a good question, isn't it? I mean, PANDAS might be easier in some ways because you may find evidence of strep, ASO, DNase, anti-streptolysin, ASO, DNase, or you're swabbing their throat for strep, or you're swabbing their bum or something crazy. But, if you find strep, that might be an indication. And you treat the strep and they get better, that's probably a good indication. The Cunningham panel is not completely specific, but it does exist with a 5 antibody panel that was designed for PANDAS type responses. However, autoimmune encephalopathies may look similar. So it's kind of maybe in some cases a diagnosis of rollout, like if there's an infection trigger, I think more PANDAS. Infections may start a process of AE, but it's maybe not as obvious. And I guess I should put ANDALS into the adult PANDAS sort of realm. That's the adult neuropsychiatric disorder associated with Lyme. It's more in the PANDAS realm. Okay. Tell me about the correlation or occurrence of MCAS along with epilepsy or locked-in states. Yeah, that's a good question because I've seen, mast cell type disorders and responses with stuff like stiff person syndrome too, where there's, neuromuscular dysfunction and sort of seizure type response and everything. Mast cells, though, they signal in a lot of different ways in the brain, and they can influence neurotransmitters, they can influence other immune cells. I mean, it's pretty complicated, but let's just say they can create excitatory responses, and some people can get, I don't know, say food or environmentally triggered seizures or food or environmentally triggered neuroexcitation responses. And I don't always have a complete answer for them, but the mast cells are often, I mean, if you stabilize the mast cells, sometimes the threshold of those seizures or whatever other responses do improve. That's all I can say. Are there specific blood tests to detect mast cell activation? Yeah, I didn't talk about those. I should probably for a minute. What a spinal tap diagnosis? The spinal tap doesn't, I'll talk about that second, but as far as blood tests go, I mean, there's histamine you can check, there's peripheral mast cell markers and cytokines, all the things I mentioned. They're not always completely specific, but it can paint a picture over time. There's the urine tests like the prostaglandin and the methylhistamine, leukotrienes and that kind of stuff. Those are really touchy though. You have to like keep the sample frozen and send it out perfectly, and the lab has to not screw it up, and it gets kind of tough. But if you can do it, the other good test to consider, it's not blood, is if somebody's doing a gut test, like say an endoscopy or colonoscopy, to get a biopsy and stain for mast cells with the CD117 blue stain, because mast cells are invisible under the microscope otherwise, but you can see if there's greater than, some sources say 20 or 30 per visual field, and they're not going to be aggregating like mastocytosis, there's probably a lot of mast cell activity in that person's gut. So that could be helpful. What would cause sudden rapid weight loss with rapid aging, 4 days, and then ongoing loss of elastin skin, suddenly aged fat under the skin, go on? Well, COVID can do weird stuff like this too. High oxidative stress is the short answer. I mean, maybe there is telomere dysregulation or dysfunction. It really depends, but you can get rapid breakdown of connective tissue and collagen and elastin. I've seen people go very, hypermobile quickly, or, get more, saggy and stuff like this. It's really distressing when that happens. Hair loss, various things. There was a study on COVID and rapid aging too. And then weight loss. Yeah, I mean, that can happen for a variety of reasons, as I mentioned, because the gut gets involved. There's cellular mitochondrial dysfunction and dysregulation. There's cell danger response and how it affects metabolism at large. There's all kinds of mechanisms there. That is unfortunately something I've seen before. What's your number one favorite supplement for treating mycotoxins? If I had one favorite supplement for mycotoxins, what would it be? It's a good question, because you can't necessarily give glutathione to everybody right away, so you got to be careful with that. I like Pectisol in a roundabout way, modified citrus pectin, because it gets into the blood effectively. It modulates galectin. There's a whole talk on that from Dr. Parpia. And it works on mold and metals and various things, and it works on glyphosate. So, maybe I'm partial to it, but if I thought about it harder, I might say something different on a different day. Okay. What treatments would you tend to try first for brain fog due to long COVID? That's a good question. Brain fog. One of the hardest symptoms sometimes until you figure out what's causing it, and then it seems like obvious or whatever, but not always. I've seen brain fog improve when I've done sinus treatments with people or they get their teeth fixed or whatever. I've seen brain fog improve when I do the gut work and the gut barrier work. I've even seen it possibly improve from gut barrier treatments directly. I've seen it improve from treating viruses sometimes if they're reactivated, treating Lyme and those types of things. Um, yeah, it's, and sometimes it is stuff like mitochondrial support that's needed. It's not always killing or removing something. And sometimes weirdly enough, just antihistamines, you'd think they'd make you tired, but sometimes they improve your brain fog because there's too much histamine activity up there from the mast cells. So yeah, it's a different answer for everybody. Can you go into more detail with mast cells, pelvic congestion, pelvic burning, and structural causes? Oh yeah, this is a heavy, heavy subject too. So as I mentioned, everybody has their own sort of individual structural arrangements in terms of vascular and other elements. Like if like myself, were in medical school and looking at cadavers and seeing each person, and then trying to go identify this artery branch or something like that, you're going to see it looks slightly different on everybody. Well, our venous system is much the same. And so what happens that we understand is that some folks are susceptible to the development of pelvic congestion or some other type of vascular associated disorder. And sometimes, like in the gut, it might be MALS, which is median arcuate ligament syndrome. It's like, the vascular and the nerve system and it's anatomical placement. Those things could lead to either impairment in the drainage of the venous system or possibly an impingement of a nerve somewhere or something. Long story short, it doesn't always happen and manifest until somebody becomes inflamed for some reason. And that's where, mast cell may be associated in some of these people because lining the vessels, the walls of the vessels, and whatever's happening, they affect the integrity of the connective tissue in those areas. It happens more in hypermobile people. Whatever happens, you get a reduced blood flow return to the heart, and then you get less blood flow to the brain. And oftentimes that can make people pass out. It can make them have more heart palpitations, like POTS. It can increase adrenaline, hyperadrenergic adrenaline responses. It can do all kinds of things, but they also can have severe dysmenorrhea, pelvic pain, um, pain with intercourse, all kinds of other things too in the pelvic area. In the gut area, they might have difficulty eating, as seen in males. I mean, it's a whole other subject. Maybe I'll talk about that sometime. Okay, how are we doing? Okay, what are the medium-term and long-term side effects or downsides of using certain medications or supplements commonly used for mast cell conditions? Could you name those medium and long-term side effects commonly and lesser commonly seen? Yeah, I mean, I'd say antihistamines aren't without their side effects. They dry you out. And central acting ones may make you more drowsy. Supposedly they could affect balance in people, especially over 65, or cognitive dysfunction. Do they prone people to I don't know, cognitive disorders, Alzheimer's, dementia later in life? There's always these questions of long-term use with antihistamines, and then the reliance on them. How easy is it to taper them after a certain amount of time? But if they improve somebody's quality of life and they're better on them than off them, I think I always try to work to get to a point where they don't need them, but they're not without their side effects. And as you move their way up the ladder, I mean, I don't use a lot of steroidal things, but even singular leukotriene inhibitors have a lot of side effect potential, depression, weight gain. There's a whole bunch there. So if I can use the natural stuff like say flavonoids and people can tolerate that, that's wonderful. And then if I can use the drugs sort of short term to stabilize them, I'll try to get them off them later if they're able to get off them, and I'll do more nutrigenomic workup or some other sort of personalized approach or treat whatever the problem is. Dandelion tincture also degrades spike protein. Oh yeah, that's great. Dandelion is awesome. Yeah, there are actually a lot of natural products that interact with spike protein incidentally. I'll try to see if I can get that list. It does exist, let's just say that, but they've been researched actually. Um, my partner had an area the size of a quarter in the brain of damaged tissue from an ischemic stroke. After contracting COVID, the area liquefied brain grew, wow, yeah, surrounded by mild gliosis. In addition, the empty cella syndrome developed, yeah, which is intracranial pressure changes usually, smashing the pituitary. Have you seen this in other patients, and do you have any treatment recommendations? Well, yeah, it's good. Methylene blue, low-dose naltrexone makes sense. Sometimes, if appropriate, temporarily lowering intracranial pressure could be useful. And there are several ways to do that. And then also, if there is qualifying the inflammatory response now, is there what's creating neural inflammation, that kind of change? Is it mast cell stuff, as I mentioned? Is it viral reactivation? Is it other elements? And then doing a lot of work for the endothelium here and the walls of the vessel and everything. And yeah, just keeping vascular inflammation down as much as possible, really. I'm not really against vaccines entirely. No, I just caution people that the causes of some of these illness responses are similar. I mean, I would encourage maybe to do Novavax or other things like that in this day and age instead of mRNA to most of my patients. But I have to tell people my patient population is like the most sensitive of people. You know, like we see the exceptions most of the time. So I just wanted to be very clear about that. What are the best labs and testing to definitely confirm an MCAS diagnosis? I think I talked about that a little bit, but nothing's perfect. It's still clinical, unfortunately. I have MCAS and I'm really struggling with insomnia. I've experienced insomnia as a side effect of some mast cell stabilizers. Yeah, that's weird, but not uncommon. Even with the best of intentions, certain agents that are supposed to address your mast cell excite your mast cells. And that's where I said maybe it's a lock and key that you need. That's not the right key for your particular keyhole, so to speak. And so you have to try other things. It's a trial and error game, unfortunately. You have to go through all the different antihistamines because some of them will work better than others. That's usually what it comes down to. So you literally may have to go through every single one of them. If the one doesn't work, check the box. That's not a good one. Go to the next one. I mentioned neurosteroids like progesterone or pregnenolone, DHEA for the brain and insomnia. It can work really well and still help and support an MCAS. Are you seeing more non-vaccinated present symptoms like vaccinated? What is your viewing on shedding and transmitting? Wait a second. Am I seeing more non-vaccinated present symptoms? Oh, well, I mean, I see probably about a split right now of vaccinated injury, and I don't see as much new post-COVID injury as far as that goes. I don't have much of a comment on the shedding thing. I mean, people do talk about it, but I don't have much of a comment on it. Have you investigated the effect of using somatic experiencing, which promotes regulation of the nervous system when calming MCAS? Yeah, some of my patients have worked with this. I think it makes a lot of sense, and that's where I was talking about different forms of non-chemical interventions for the brain, the mind body, neurofeedback and brain retraining programs and other things, and it does wonders for MCAS for sure. So don't neglect that. Uh, let's see. What has your experience been with Amlexinox? It doesn't work for everybody. I don't think it has a lot of negative side effects either, though. So, I mean, I would certainly try it as a rotation agent. I've seen it work for a few people. And so, I mean, I use it as once again, it's trial and error, unfortunately. Sorry. Are there any functional neurologists you'd recommend who understand MCAS? Yeah, there are a few. Dr. Eileen Ruhoy formerly worked with us. She's just, busy most of the time, but she understands MCAS and she's a functional neurologist in the Seattle area. And there are a few others. Shoot, off the top of my head, I'm not remembering their names though, but that's one I've worked with directly. Can you repeat what you said about the therapeutic applications of peptides? Oh, in terms of what peptides? I think I went over that already, but yeah. For those with MCAS, if they have conditions that have high biofilm that needs to be penetrated and cleared, do low and slow approaches work? Yeah, low and slow with biofilm therapies and a lot of mast cell stabilizers probably, and a lot of detox support. You never know what you're getting out of there. And those fibrinolytics I mentioned that help break the fibrin and the microclotting things will also disrupt biofilm sometimes, so you want to be careful. This lab, T-Labs, has like a blood biofilm analysis. There used to be other labs that did that, but I find that to be kind of an interesting thing to look at sometimes when you're expecting infection contributions. Serapeptase, this person was using this, which was really helping tachycardia. I've seen that. I've seen it help palpitations too. It's really cool. Then they seemed to change it and it wasn't working. Yeah, that's annoying. Nature Medic, sorry, Nutrimetics was it? I think had a clean one, but I have to say that with mast cell, one product will work really well and one won't, and it may be because of excipients and other additives too, and that's kind of a weird thing. So you may have to just try different products regardless, but try to get the one with the least amount of excipients, additives in it, basically. Almost at time. I'll take a few more questions though. This person was also, okay, yeah. Have you noticed GLP-1 stabilizing mast cells? Yeah, actually, I think that's cool. I know GLP-1s get a pretty bad rap right now because like they seem like too easy of an answer to weight loss, which I totally understand the sentiment there. They also can slow gut motility and all this kind of thing. But in MCAS, I'm not using really high doses of them usually. And I've seen good effects. And some of my patients have a metabolic disorder either because of their MCAS or because of their chronic inflammatory responses in general. And those folks can have a lot of insulin resistance and other things. And I've seen the GLP-1s improve the insulin scores, the hemoglobin A1Cs, and the the insulin, the fasting blood glucose, the CRPs, the lipid panel. I mean, so it works really well for that intended purpose. But it's part of a bigger picture. It's part of a bigger story. So yes, I have seen it help. Post-COVID AFib. What have you tried before resorting to ablation? Oh, that's a good question. I have used colchicine before. Has it directly helped with AFib? That's a good question. With AFib, kind of like that previous person said that they've maybe had some help with tachycardia from fibrinolytics. I've done the microclot work does sometimes help AFibs and SVTs and other things like this, treating other endothelial or vascular stressors, whatever those may come, whatever forms they may come in, and then regulating the autonomic nervous system because it is a form of dysautonomia too, most oftentimes, even if it's in the circuitry and you don't always know, are there additional adrenaline responses being created, from vagus, I don't know. There can be other nerves involved, not just the direct nerves in the heart all the time. And it's common with Lyme syndrome. So, just to throw that out there. Let's see, I'll take maybe like two more, I think, because we're about at the hour. Is it the case that IV supplements or other IV therapies done weekly help a sensitive MCAS body get back into homeostasis faster? Or is that the level of intervention typically too much? Well, I mean, you have to go low and slow with it, and I do think that we start oftentimes with IV minerals and hydration, which makes a lot of sense for MCAS and a lot of the physical manifestations. But what's interesting is if you, in a sense, sort of overcompensate the ions, which are like the minerals and stuff like that in the system, sometimes you can temporarily calm down some of the mast cell and dysautonomia responses. It particularly works really well with POTS, for example, or that type of dysautonomia. But you may also see lower reactivities. And then if you're going to go into higher planes with other IV nutrients, you have to start low, slow, and chill. And the minerals and the hydration stuff tend to be the best way to start there. And then you can start to desensitize and add more things in later. Are the brain retraining programs that much of a game changer or usually a minor part in the healing goals? They're a game changer for some people at certain points in time. I have to say, alone, I imagine they probably have helped people alone, but those people usually don't end up seeing me because, they may have figured that out already. My patients usually need a lot more than just that, just to be very fair that's my bias. And then it says, do you believe anything is more effective than primal trust, which I heard from multiple sources seems to do better for those with mast cell than Gupta? Yeah, I mean, I think primal trust and Gupta are somewhat similar I haven't personally used both of them in comparison, but I think is in terms of what people report to me in outcomes, yeah, Primal Trust and Gupta have both helped my mast cell patients. DNRS is a little more challenging for some of those people for whatever reason, and chronic fatigue people sometimes, although they've improved their systems over the years, so I don't want to say they've helped some of my patients quite a bit still. What are the accuracy differences? I'll do one more. How about that? Or I'll do two. I like that stem cell question. Why not? Okay, so what are the accuracy differences between the urine and blood tests for pinpointing what kind of mast cell or histamine issue is at hand? Well, yeah, the problem is that these signals are not static too. So you're gonna catch a different signal on a different day and a different time from a different stressor or something like this. And so is urine better than blood? I mean, not entirely. Ideally, you would do all of it if you really wanted to be objective. If you really feel strongly that you need to be objective. And there's a time and a place for that. Like I've known allergists, for example, who are big deniers of mast cell activation when we're clinically diagnosing them, and they're just like, all those naturopaths, like they just overdiagnose it. Those functional practitioners, they don't know what they're talking about. So if you need to try to build a case, I still think I've been although it's still controversial, but I've been more effective at finding large mast cell amounts in gut tissue, for example, because most of my mast cell patients have gut symptoms, and eventually they end up getting endoscopies and colonoscopies, but you don't have to subject them to that just because. But that's an opportunity you can take if that does arise. And I think I've had gastros at least acknowledge that that's a lot of mast cell activity going on there. It's not mastocytosis, so I don't know what to do with it, but there's a lot of mast cell activity going on there. So if you're trying to prove a point, doing as much as you can makes sense. And I do have to do that for some of my patients, but this is still a clinical diagnosis, unfortunately. Will stem cells help with MCAS? Well, they could, but be careful because you're taking in somebody else's stem cells, right? So any foreign matter introduction into a mast cell activated system could be reactive, so be careful. Acellular systems may be better to try first, like exosomes, for example. Exosomes are expensive, like mast cell, stem cells too, but they may be less likely if they're fresh, clean, proper exosomes to lower inflammatory response, especially in the nervous system. Will they have a diminishing effect if you don't fix the cause of the problem? Possibly. Are they an expensive Band-Aid sometimes? Maybe, but they can also be a really valuable part of sort of the conclusion, healing, regenerative phase of a complex chronic illness treatment, which everybody needs that. The person talked about aging rapidly. Like, if you can get the inflammation down, get the fire under control, get all these other ducks in a row, so to speak, the cell danger response is calming, and you have that momentum of healing, accelerate it any way you can, if that's stem cells, if that's exosomes, if that's peptides, if that's true dose, which is IV PRP, I'll talk about sometime. It's kind of newer-ish. There's a lot of things to do at that phase of the game. So yes, please, if you have the money and the resources, but there's some things that are cheaper than others. Like peptides are definitely cheaper than stem cells and exosomes. Okay, I think we did it. I appreciate all the questions. These have been great.